The next talk is on clinical relevance of carbohydrate intolerance breath testing and will be given by Heinz Hammer from Graz, who is the leader of our guideline initiative. We are looking forward to your talk, Heinz.
Ladies and gentlemen, in the previous presentation, you were introduced to the processes involved in carbohydrate malabsorption. And as an example here, the normal digestion and maldigestion of lactose, the diagnostic modalities we have associated with that, and bacterial metabolism in the colon. In my presentation, I now want to put the focus on the clinical relevance of carbohydrate malabsorption and intolerance testing. And related to this are questions about the role of concurrent diseases, not only in the colon, where diseases like the IBS may interfere with perception of metabolic products of carbohydrate malabsorption, but also up in the small intestine, where we also already have pathophysiological changes induced by maldigestion, like osmotic water accumulation. I also want to repeat the message that carbohydrate malabsorption and intolerance describe different clinical entities which may, but not necessarily, have to overlap. I want to point this out based on the results of our previously published paper on the validation of the carbohydrate perception questionnaire, where we have found out and confirmed previous results that of 269 malabsorbers, only 41% had intolerance. That is, 59% had no intolerance. And the other way around, of 335 intolerant patients, only 47% had malabsorption. So in fact, and I want to repeat what had been said by Johann Hammer in his presentation, that malabsorption and intolerance may, but not necessarily, have to overlap. Now, what is clinical significance? It is, according to these definitions, the practical importance and whether it has a noticeable effect on daily life, or how effective is the intervention or treatment, or how much change does the intervention or treatment cause. I want to approach this pointing out the following clinical questions. Is intolerance a sufficient explanation for the symptoms of the patient? What are the best options for improving symptoms? And how can the patient's quality of life be improved? What do we know about this? Do we know the clinical significance of testing for malabsorption and intolerance of carbohydrates, especially now at a time when a new focus has been laid on the relation between intolerance and intolerance being independent from malabsorption? Why is there currently only few evidence for the effectiveness of clinical interventions for the treatment of lactose? Treatment effects of lactase or diet or antibiotics have been nicely summarized in this review. However, the result was that the level of evidence for all of these interventions, lactase supplements, probiotics, rifaximin, diet, is insufficient. Why is that the case? Now look at the time when this review was performed in 2010. And the problem then was there was no upfront definition of and distinction between lactose malabsorption on one side and intolerance on the other side, and therefore flawed patient inclusion. Please remember that I have informed you previously that 50% of patients with lactose malabsorption will not have lactose intolerance. However, inclusion into these studies summarized here was mostly by hydrogen breath testing. So included were patients with lactose malabsorption. They got an intervention, and at the end, they were asked for symptoms. So in fact, the comparison was between apples and pears. Another problem is, and this relates to one of our own studies, like this one here with oroxylose isomerase in fructose malabsorption and intolerance, is that these are often small studies in selected patient groups. Why is that the case? Do the authors of this study, and I was one of them, not know about the problems of small studies? Well, they do, but the background of many of the supporting companies, and the fact is, scientific research relies on financing, if not by public agencies, then by interested pharmaceutical companies. But now in this field of food intolerances and of potential interventions with regard to intolerances, we do not have sponsors who are interested in the big studies, and also like not in this one, where the background was that of a nutrition supplement company. And that also relates to all or most of the studies in lactose intolerance, in where lactase supplements were tested. And again, these studies summarize both of these problems. No upfront definition and distinction between malabsorption and intolerance, and a flawed patient inclusion. And the second problem, small studies in selected patient groups. The new European Breath Test Guidelines want to put the starting point for future scientific studies in this field by defining and clarifying patient definitions, and therefore homogenizing the patient inclusion criteria by definition of and distinction between the terms of malabsorption and intolerance, by a focus on the relation between malabsorption and symptoms, by identification of validated symptom assessment tools for carbohydrate intolerance in adult and pediatric patients, by recommendation to combine malabsorption testing with validated symptom measurement, and by recommendations on future research needs. I want to show you some of these statements from this breath test guidelines. The results of hydrogen breath testing with symptom assessment for lactose malabsorption and intolerance have acceptable sensitivity and specificity for a clinically relevant condition and can directly affect therapy. And there was 84% agreement on this in the guideline process. Minimum reporting criteria of a breath test used to detect maldigestion or malabsorption should include a statement whether there is evidence of maldigestion or malabsorption and of intolerance, with 100% agreement for this recommendation in the guideline process. The recording of symptoms both in the adult and in the pediatric patients after carbohydrate ingestion is an integral part of a carbohydrate challenge test, with agreement rates of 97 and 95% in the adult and pediatric recommendations. And finally, another important statement: the combination of carbohydrate breath test with symptom assessment allows for the determination of 4 different entities after a carbohydrate load. First, the maldigestion or malabsorption plus symptoms, maldigestion or malabsorption only. symptoms only, and 4, none of the above. In this guideline manuscript, future research needs were identified. The one first is the translation of the validated carbohydrate perception questionnaires from the German and English version to other languages to advance international cooperative research projects. The second is clinical research into treatment and detection of specific intolerances in, for example, IBS, therapeutic trials in patients with a documented carbohydrate intolerance to improve knowledge about the rational use of treatment options. Studies to address whether in diseases like IBS, the treatment of specific intolerances, a dietary precision knife approach, that's how we called it, based on identification of specific intolerances, will improve the patient's quality of life, costs of living, long-term safety, health outcomes, as compared to empirical and less specific broad dietary advice like the FODMAP diet is, a dietary shotgun approach. That's how we call it in our manuscript. Studies to examine to which extent validated measurement of symptoms of carbohydrate intolerance will find a place as an adjunct or even a replacement of breath testing. And last but not least, development and application of an app-based validated symptom questionnaire to assess carbohydrate intolerances, which is in the process nearing completion and will be named carboception. The new European Breath Test Guidelines, Statement 226, put a focus on this research needs. And this entity needs further studies as to its pathogenesis and therapeutic relevance, and this is mostly related to the entity of patients who have intolerance but no malabsorption. What are the next steps for you who listen to this presentation and who want to get messages how to proceed right now, tomorrow, and the day after tomorrow? I suggest for you to right away start including symptom assessment in your carbohydrate malabsorption and intolerance testing. It would be optimal to use the validated ACPQ and PCPQ, which have been published in English and German language. And to restrict treatment with diets and supplements to patients with documented intolerance. Not malabsorption is the indication for treatment, it is intolerance. And I suggest to test patients with IBS-like symptoms for intolerance to specific carbohydrates and consider specific dietary exclusions rather than broad dietary restrictions. This is the European Hydrogen Breath Test Group. And if you're interested to join the breath test group, please send me an email and have a look out for the new European Breath Test Guidelines in the UEG journal. Thank you for your attention.